Good afternoon, dear colleagues. I would like to thank organizing committee, especially Professor Lee, for inviting me. It's a great honor for me to be here and share our experience. Today, I would like to talk about mild anastomosis during the living transplantation. Biliary complications are the technical Achilles heel of liver transplantation. According to literature, the overall incidence of biliary complications range from 7 to 39% of this bile leakage, up to 23%, biliary stricture from 6 to 39%. Classification of biliary complications after liver transplantation divided into the localization type, the timing of occurrence, etiology, reconstruction, and other very rare complications. When is the biliary anatomy contraindication? There are no absolute contraindication for liver transplantation based only on bile duct anatomy. All types of biliary anatomy in the donor are acceptable. Of course, the risk of biliary complications are different, but a combination of complex vascular and biliary anatomical variants can lead to surgical risks that overweight potential benefit. It's multiply separate right hepatic duct requiring more than 2 orifices in the graft can alleviate the risk and may be deemed unfavorable. This is a relative contraindication. How do we do biliary anastomosis donor operation? I mentioned before, multiply more than 3 separate right hepatic duct combination with complex vascular and biliary variants. We use open approach, intraoperative cholangiography, 3 times before transection, after transection, after hepatectomy, minimum dissection, less injury. We save the liver plate or the parenchyma more. The next slide shows lines indicating safe and unsafe zones for dissection of the right hepatic duct. Division of the posterior Wilson's tissues in the area of the hilar plate after transection of the right bile duct should be directed closer to the left side, plane B, and not along the midline of the liver. This is necessary to prevent injury to the right posterior bile duct and to preserve sufficient Wilsonian tissue around it. The lower images shows a line indicating the safe dissection zone for the right hepatic duct. In this slide, I wanted to highlight the importance of preserving the donor bile duct parenchyma. To preserve bile duct tissue during living donor right lobe liver harvesting, surgical teams use the following approaches. Use precise transection techniques to avoid unnecessary lost tissue around the duct. This incidence and the risk factors for biliary complications after liver transplantation here show the main complications, and the risk factors are divided into donor, recipients, and the surgical related factors. Here, the complications more common for LDLT are underlined. As shown, the living donor already is risk factors. There are incidents of biliary complications after LDLT. The slide shows the long-term results of biliary complications of Japanese colleagues, where you can see there is a decrease in bile leakage and the number of strictures doesn't change. In our results, bile leakage doesn't change, but numbers of biliary strictures decreased after liver transplantation. I mentioned before some factors for reducing biliary complications. Of these, more important, carefully surgery, external biliary drainage. After leakage often occur stricture. And one of the important points, this stage of the operation in our clinics performed only by experienced surgeons. The very one of the important things, the carefully flushing bile ducts in the back table. Why? The reason remove toxic bile, benefits prevent epithelial damage, lower infection risks, prevent cholangitis and abscesses, avoid sludge stone formation, reduce risk of obstruction, improve bile flow, and the benefits support the graft function. How do we do biliary anastomosis? Recipient operation. During the anastomosis, we use only surgical loops. We don't use a microscope, suture materials, PDS. Depending on the level of the recipient's bile duct, we perform the anastomosis at the level of the hepatic common bile duct, the level of the confluence using the telescoping techniques, the level of the segmental ducts. Biliary drainage is used only externally and used in the following cases. Diameters of the bile duct less 3 millimeters, ductoplasty, and the double bile duct. Techniques prevent biliary complications after LDLT, the minimal hilar dissection, mucosal eversion technique, cholangiojejunostomy, telescope reconstruction, and external stent. The minimal hilar dissection this has potential for preventing biliary complications by preserving the blood supply of bile duct. We use this technique for ductoplasty and the double bile duct anastomosis. We don't use en bloc resection. Firstly, we mobilize the left hepatic artery after left portal vein to receive the long branch of the left hepatic bile duct. Next step is a minimal mobilize the right hepatic artery to main blood supply to the bile duct. After that, we clamping right hepatic artery using bulldog. After we mobilize the right anterior hepatic artery and the right posterior hepatic artery. There is several options for biliary anastomosis technique in LDLT. The slide shows the main types of biliary anastomosis techniques. The choice of method depends on the anatomical features and allows for optimal restoration of bile flow and minimizing the risk of complication. Here is mucosal eversion technique, biliary anastomosis, which was recommended to our Korean colleagues. We use these techniques to create the single bile duct anastomosis. If there is no tension, we perform the anastomosis at the level of the hepatic choledoch and use the mucosal inversion technique. Some others recommend cholangiojejunostomy for reducing the bile complications. Of course, strictures rate lower, around 6%. But higher risk of septic complications, limitation. It's while using, we use this method according to the indication showing on the slide. We prefer the duct-to-duct anastomosis. Telescopic reconstruction of bile duct in LDLT and this techniques results is excellent outcomes by maintaining vascularity and the bile duct size matching. We use this technique in the following cases during ductoplasty when there is tension on the hepatic duct. What about the external biliary drainage? Indication, living donor liver transplantation with multiple duct or small duct size, pediatric liver transplantation, split liver transplantation. When we use external biliary drainage, diameter of less than 3, ductoplasty, double bile ducts. Unfortunately, sometimes developing stent-related complications. Of course, the profit external drainage overweights complications. The advantages, external biliary drainage, decrease of biliary complications in LDT, early diagnosis of biliary complications, checks the quality of bile nature, identifies the location of the bile duct during PDDP, improves the bile excretory function. Disadvantages, pain of the tube, abdominal pain, and accidental removal, one of the dangerous complications of the external stent, and the peritonitis. Here, the Asan Medical Center data shows the dramatically decreasing number of the biliary complications in stenting group. Our data also confirms the effectiveness of using external biliary drainage to reducing the risk of complications, especially bile leak in the postoperative period. Biliary complications in our case experience occurs in 18% cases, so all strictures, 13% leakage and biloma, and 6% patients developed. So the interesting is half of patients with bile leakage, the late postoperative period, developed the biliary stricture. It's very important. Prophylaxis leakage is very important things. Biliary complications, its frequency and effectiveness treatment depend on the experience. Of course, we divided our experiences the two periods. In initial periods, biliary complications was at a high rate. After in the second periods, decreased dramatically, 2 times biliary complications. Effectiveness of mini-invasive treatment increased to 27%. It's very important. Here is all our cases, variants of biliary reconstruction. This is our experience, including the little group with patients with disease donors, including the pediatric donors. This data demonstrates the diversity of approaches of biliary tract reconstruction depending on the anatomical and the clinical features of each case. Here, conclusion, types of biliary anatomy are not acceptable. It's a very important things. It's prophylaxis is leakage, because leakage is one of the main reasons of developing strictures of late period. Please, video.
First, it's single bile duct anastomosis, donor's cholangium before transection and after transection, dividing donor's bile duct. Here is the recipient procedure. We prefer mucosal eversion technique, as you see on the skin.
Here is a mucosal eversion techniques.
At the end, we complete anastomosis and control recipient's cholangium. And now ductoplasty, donor's cholangium before transection and after transection. Dividing bile duct of the donor with safe more parenchyma. As you know, this is considered a very important step for the prevention of biliary complications. This is a backstable stitch. As you can see, we measure and prepare the bile ducts for the ductoplasty. Ductoplasty is now performed. Now it's going preparation of the anastomotic site using the telescopic technique. Measurement distance between of the bile ducts. During the anastomosis, we performed carefully hemostasis, and we do not use coagulation during the hemostasis. Now it's going beginning of the anastomosis. posterior wall suture of the anastomosis. Due to the small diameter of the bile ducts, less than 3 mm, we used external biliary drainage. Now you see anterior wall suturing. Peritonization of the external biliary drainage is performed. And final view and control cholangia after implantation. Now double bile duct anastomosis, donor's cholangia before transection and after transection. Dividing bile duct of the donor as shown schematically and where you can see the two bile ducts. Minimal high hilar dissection stage. We use this technique for ductoplasty and double bile duct anastomosis. We mobilize the left portal vein to receive the long branch of the left hepatic bile duct. Minimally mobilize the right hepatic artery to maintain blood supply to the bile duct. We dividing the recipient's bile ducts after crossing the donor's bile ducts. Measurement the distance between the bile ducts. Preparation for anastomosis. Distance between the ducts was 1.2 centimeters. Next, anastomosis between recipient's left hepatic duct and donor's right anterior hepatic duct. Performing the posterior wall suturing. And we use external biliary drainage. Finishing the anastomosis, and next anastomosis between the recipient's right hepatic duct and donor's right posterior hepatic duct. Performing posterior wall suturing using external biliary drainage. Anterior wall suturing and control cholangia after implantation.
Thank you.